Welcome to The Explainer. Today we're doing a deep dive into the Monteggia fracture in adults, a notoriously complex injury that every single orthopedic surgeon needs to master. Okay, let's get into it. We're going to structure this just like a Viva exam. We'll start with the definition and classification, move through assessment and treatment, and then wrap up with the evidence and potential complications.
All right, so let's start by framing the challenge here. Why exactly is this injury such a big deal?
You know, this classic quote from Watson Jones just hits the nail on the head. It perfectly captures the tough reputation of the Monteggia fracture. And honestly, even with all our modern tech and implants, that sentiment still rings true. It really highlights why having a flawless, systematic approach isn't just a nice idea, it's absolutely essential if you want a good outcome. So what is it exactly? Well, first described way back in 1814 by Giovanni Battista Monteggia, this is the core definition you've got to know cold. It's not just a broken ulna, it's the combination of that ulnar fracture with the radial head dislocation. That's what defines this specific and, well, challenging injury.
Okay, let's talk classification. And look, this isn't just some academic box-ticking exercise. Understanding these different types is basically the roadmap that's going to dictate your entire management strategy.
The Botto classification. It's the one we all use, and its beauty is in its simplicity. It's all organized around one single factor. Which way did the radial head dislocate? As you can see, type 1, the anterior dislocation, is by far the most common when you count all age groups. We're talking about 60% of all cases.
But here's a really crucial distinction. A real clinical pearl for adult practice. While type 1 is number 1 overall if you include kids, in the adult world, which is what we're focused on today, the script completely flips. The Botto type 2, with its posterior dislocation, is the pattern you're going to see most of the time in up to 80% of your adult patients.
So because these Botto type Ts are so common in adults, Jupiter came along and added another layer of detail. This subclassification is all about the exact location of the ulnar fracture. It forces you to ask the important questions. Is it in the joint? Does it involve the coronoid? The answer to that is going to have a direct impact on your surgical approach and what hardware you choose. And here's a perfect example of a Jupiter type 2A. Just look at this. You can see that fracture line running right through the olecranon, and, most importantly, into the coronoid process. This makes it an inherently unstable injury because you've knocked out the primary bony stabilizers of the elbow joint.
And here you can see how the pattern moves further down the bone. On the left, you've got that type 2B right at the metaphyseal diaphyseal junction, and then on the right, a IC, which is a true shaft fracture. Each of these presents a slightly different biomechanical puzzle and is definitely going to influence how and where you place your plate.
All right, let's move on to clinical assessment. And listen, this is where you can really get into trouble if you're not careful. A meticulous, systematic exam is what keeps you from missing this diagnosis, which is one of the biggest traps. So, you have to be systematic here. I mean, of course you're going to inspect for the obvious stuff, but palpation is key. You have to feel for tenderness, not just over the ulnar shaft, but very specifically over the radial head. And before you even think about assessing motion, a detailed neurovascular exam is absolutely non-negotiable, and you have to document it.
Now, this is a big one. You absolutely have to specifically test for pin function. It is the most commonly injured nerve here, usually from getting stretched as the radial head pops out of place. The signs are classic: weakness of thumb and finger extension, and then, when you ask the patient to extend the wrist, it'll pull over to the radial side. Missing this is a huge deal for the patient.
When it comes to imaging, there's one rule you can never ever forget. Get the joint above and the joint below. An isolated X-ray of the forearm is a classic mistake because you will miss the radial head dislocation. And for any complex pattern, especially a Jupiter type 2A, or if you even think there might be a radial head fracture, a CT scan isn't optional, it's mandatory. You need it for proper pre-out planning.
Okay, so how do we fix this? Let's talk definitive management. And let's be crystal clear, in an adult, this injury almost always means a trip to the operating room. Now, you might be thinking about what we do in kids, closed reduction and a cast. You've got to get that idea out of your head for adults. That strategy just fails. Open reduction and internal fixation, ORIF, is the undisputed gold standard. You have to restore the anatomy, get it stable, and allow for that critical early motion. The entire surgery, literally the whole thing, hangs on one single elegant principle.
Get the ulna perfect. If you get an anatomic reduction, restoring its length, its alignment, its rotation, the radial head will, in almost every single case, just pop back into place on its own. And of course, you have to confirm that perfect reduction with an image intensifier before you even think about closing.
And there it is. That is the goal. This is what a successful surgery looks like. You've got rigid anatomic fixation of the ulna, which in turn has perfectly reduced the radial head. The radiocapitellar joint is lined up beautifully, and you've created a stable platform for that essential early rehabilitation.
Okay, so you've done the surgery, but we're not out of the woods yet. Let's talk about the evidence, the complications, and the potential pitfalls you need to be watching out for, and of course, counseling your patient about.
These are the big ones you've got to have on your radar. And do you notice a pattern here? Malunion and non-union are almost always a direct result of an imperfect ulnar reduction. And elbow stiffness? That's the enemy. And it's a direct consequence of a delayed diagnosis or unstable fixation that prevents you from getting the elbow moving early. The quality of your initial management is everything.
So you might be wondering, what do we do about that pin palsy we found earlier? Well, the evidence is pretty clear on this. If you diagnose one, the standard of care is active observation. The nerve has almost always just sustained a stretch injury, a neuropraxia, and it'll typically recover on its own in 2 to 3 months. You have to resist that urge to go exploring it acutely.
All right, let's wrap this up and boil it all down to the key takeaways from our consultant-level review.
Look, if you take away just 3 things from this whole discussion, make it these. These are the absolute pillars of a successful outcome. Number 1, recognize the injury early by looking at the joint above. Number 2, execute a perfect anatomic fixation of the ulna. And number 3, use that stability to get the patient moving early. That's how you prevent a stiff, dysfunctional elbow. So, I'm going to leave you with this final thought, a question to really integrate into your own practice. What's your personal strategy to make sure you never, ever miss this injury? Because having a system is what ensures you're always ready to identify and manage this really challenging problem effectively.